we have two distinguished panelists that will be talking about these issues, whether electronic medical records are a panacea or a real privacy problem. Pamela Lane is going to get us started. She's the Vice President of Health Informatics for the California Hospital Association. She has a long background in the healthcare field. And she may even reveal a private fact of a journalist background. Is that right? Yeah? Okay. All right. And Lee Tien is our second speaker. He's Senior Staff Attorney with the Electronic Frontier Foundation here in San Francisco. He specializes in free speech and privacy law, and he advises the California Health and Human Services Agency on medical privacy issues. And so, Pam, why don't we get started?
Sure. Well, good afternoon. We're delighted that you're here in San Francisco and in beautiful Northern California. I think every speaker should have a little surprise in their pocket. And I did not disclose previously that I have a history of another life before healthcare, and I was the managing editor of a newspaper. So I know how you think, and I know how you're going to ask me those questions. We were the bad panel. We did not get our handouts and our information in on time. Lee slipped his in. I did not get mine copied. But I'm going to talk less about privacy and leave that to my colleague as his area of expertise, and more about the general overview of what's going on in EHR world today. The handout, which I will make available to you through your organization, is actually a document that has recently come out of the Office of the National Coordinator's Office, and it is the National Strategic HIT Plan from 2011 through 2015. It's a very, very interesting document because they have shifted focus from where all of this started, and I promised Andy that I would do a little retrospective on how we got to this place. And I'm going to do it in classic journalism style and try to address our 5 W's and the H. First of all, I think that thinking that EHR is the answer is wrong. EHRs are tools. They're just like any tool you have in your house, your mixer in the kitchen or your trouble light in the garage. They're only as good as the product that you buy and the way that you apply it to what it is you're trying to do. So, but what we're trying to apply it to as a country, as a nation, is transformation. And so I would shift our title a little bit from my part of the panel and say that transformation, is it a mirage? Or is it a miracle? Or is it just the promised land that we'll probably, maybe in 40 years, get to? You know this as well as I do, and I don't want to preach to the choir, but in 2009, the American Recovery and Reinvestment Act was signed by then brand new President Obama. The focus at that time was jobs, 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 jobs. And embedded in that act was another act called high tech. Now, when we say that, people think that we're talking about high technology, but that is not what the acronym high tech stands for. And the key, I believe, to all of this transformation is actually in the words that that acronym represents. That was health information technology for economic and clinical health. So within that acronym, we have both economic and quality. And that's really the transformation that we all are hoping occurs. I'm going to focus more on the why and the how, because that's really what's tripping us all up at this point, the how particularly from my constituency groups of hospitals, but the why is economic and clinical quality health. Now, whose economic and clinical health? Well, it's not hospitals, because the mandates for the EHRs, which, by the way, when you get the handout, you'll see EHR is at the very bottom of a 5-tiered process, and transformation is at the top. EHR is the tool, and as you progress up this 5 tiers, you get to patient empowerment, you get to better outcomes, you get to all of the things that we're hoping to use the tool for. But in the meantime, CMS is throwing a carrot and a stick out there for hospitals, clinics, providers to incentivize them to put in electronic health records. But if we're going to transform care, it really isn't about the provider so much as it is about the patient. And the reason that why CMS is doing this is for their own economic health. Because if we have the data, information is power. If we have the data that we can transform to information or informatics, in my world, then we can make informed clinical decisions and look for evidence-based outcomes that will actually change the way we care for people. I have a personal story, and I would challenge each of you, not so much at this point to focus on privacy, although I have lived and breathed that for the last 4 years, serving in an advisory capacity to the state, but focus on the patient and look for the situations and the times when the information being available saved a life. And that actually happened in my family, not the way I would like. It was not electronic health information exchange. My father was here visiting with me. He and my mother left with their fifth-wheel RV driving back to their home in the east. They got over to the middle of Nevada, in the middle of nowhere, literally in the middle of nowhere, and my father became very acutely ill and slumped over the steering wheel. My mother looked up. There's a blue hospital sign. Both my parents are retired healthcare nurses, and my father was the acting CEO in one of the hospitals in Georgia for a while, one of the critical access hospitals. So this is my family business. Anyway, so my father ends up at this hospital. He's one of 2 patients in the hospital. They happen to have a state-of-the-art, brand new CT scanner. They do a CT on him to try to find out what's wrong. They take care of the pain issue. I go over to get him, to bring him back here, try to figure out how to get the RV and the pets and everything back home. Before we left that hospital, I thought to ask, can you burn me a CD of that CT scan? Because sure enough, the minute we got back here, and he had another episode, I had to take him to the emergency room. What's the first thing you think that emergency room doctor said we're going to do? A CT scan. So right there's economic health for payers. Tests are not being repeated. Patients are not being put through retesting. And my father turned to me at that point and said, this electronic health record stuff, get this fixed. Right, Dad? I'm right on it. Got to get it fixed just for you. The availability of that information made the difference in his care and in the speed of his care. California has over 5 million emergency room visits a year. 5 million emergency room visits. And if every single one of those visits had just one element of data available from a previous encounter that did not have to be repeated, think of the impact to the financial end of medicine. Now, obviously, the quality part, we all know we've been focused on that for a long time. We know CMS is going to use some quality reporting that they're mandating to reduce payments. Again, economic health for them. But the EHR is simply the tool. That's the why. How and the challenges that hospitals are having, well, the how is the challenge. This program started with very little forethought, and we were asking hospitals and physicians, your family member, to put in an electronic health record that was certified to national standards, but we didn't have national standards. I sat on a federal panel where they were trying to develop standardized data elements, and they could not agree on gender. I don't think there's a lot of choices there, but the data choices become, is it A, B, C, D? Is it alpha? Is it numeric? We have to have male and female. There are times when we have to have unknown. There are times when we have to have another choice. So that becomes, just that one data element became extremely problematic. And how are we going to standardize systems to gender? Imagine, if you will, all the other factors and data elements that are problematic. Hospitals' challenges in this world are conflicting mandates. A story idea for you is to go back home and find out where your state and payers are, particularly your Medicaid program relative to the ICD implementation. We found out last week that Medi-Cal, California's Medicaid program, is not going to be ready on time. That's mandated by HIPAA and the HIPAA 5010 standards. So these are questions you can ask, where are you with the HIPAA 5010 testing? And the implementation date for ICD-10 is 2013. Will your state be ready for that? And if they're not, and your providers can't bill, and their cash flow dries up because they can't process claims, what does that mean to your communities and your state? So that's a conflicting mandate. ICD-10 was a mandate long before high-tech came into play. Workforce is a problem for hospitals because these are not IT. There's not a shortage of IT workforce. There is a shortage of healthcare IT workforce. One of the biggest challenges for hospitals is they need to look at all of their workflow design and redesign it so that they don't automate chaos, but they actually get more efficient systems and processes in their hospitals. Andy mentioned the return on investment, and the former National Coordinator for Health IT, Dr. Blumenthal, just had an article this past week, and he was talking about the fact that we as a country cannot look at a return on investment in EHR technology based on dollars. We're going to have to look at it based on quality. And how do we quantify the value of quality? That goes back to that old question, do we even know what quality is? We know when we don't see it, but do we even really know what it is, and how do we quantify that return on investment? And then there's the language and understanding. This is acronym soup. When I started 20-some years ago, looking toward a time when there was paperless records, one of the first acronyms that came out from some very, very savvy think tank people in Washington, D.C. was around this idea of computerized patient records. Computerized patient records, we're going to call them CPR. I'm not sure that's the best acronym you could come up with in healthcare. It's going to get a little confusing. Now, do you know the difference between an EMR and an EHR? There's a difference. So we're creating a new language, and people have a learning curve relative to that. Even the idea that we're talking about the same thing when we use an acronym is problematic. So your story ideas from me are a HIPAA 5010, ICD-10 investigation of look for the providers in your town. Ask your family members and physicians, clinics, hospitals in your town where they are with their preparation for ICD-10.
Tell us
what that is. I spent this whole week learning it. That's why I didn't get my handouts ready for you. ICD-10 is the International Classification of Diseases. This is the 10th edition. This is created and overseen by the World Health Organization. We are the last country in the civilized world who is not on ICD-10. ICD-10 was actually first created in 1979, but because the United States uses this for a reimbursement system, we have to sort of take it and then turn it on its side. It's really the classification system for reporting diseases and procedures. We use it for billing and its claims data here in the U.S., but we are way behind it. ICD-11 is already out, and we're just now going to ICD-10 in the U.S. Find out about the patient. Find out about the time when, not when information was breached, but when information availability saved a patient's life. Because we hear about the breach stories. Those are sexy. They make headlines. They sell papers. It's always a lot of numbers. It's a lot of people. And it's horrible. Let me just say right up front, who in here is not a patient? Is there anybody in this room that is not a patient? So when we talk about the patient, when I talk about the patient, I'm talking about me. It's all about me. So a patient privacy breach, and oh, by the way, mine was one of the first ones that was a national report on the VA missing laptop. Guess whose data was on that laptop? So those are sort of the low-hanging fruit stories, in my opinion. They're horrible. I don't want to minimize that, but find out about the flip side of information availability. When the information availability to a provider in an emergency room or in a doctor's office saves someone's life. What happens when we bring all these uninsured people into the Medicare and Medi-Cal programs and we have no medical history on them, and suddenly they're showing up for care? How are we going to get information on them? Where? There must be information on them somewhere. Where is that information? And then my question, and always a challenge, because I'm in the sandwich generation, where I'm sort of overseeing the care or concerned about the care both of those in my family who are younger than me and those in my family who are older than me. My hair is getting grayer by the day, so I am part of the graying of America. And so the question is, who is the patient? And just like a hospital, when you've seen one hospital, you've seen one hospital. When you've seen one patient, you've probably seen one patient. How did I do? You didn't pull the hook.
Talk about meaningful use and what that is.
Oh, that's one of those new words we came up with. Yeah. Meaningful use. Isn't all use meaningful? Well, meaningful use is the standard, the regulatory standard by which providers and hospitals and clinics will receive incentive payment dollars. So, if I'm a hospital and I want to receive incentive dollars for implementing an EHR, I have to not just have implemented it, but I have to be able to prove to CMS that I am using that system in a meaningful way. Meaningful use is designed to be in 3 stages. We're currently in stage 1, where hospitals and physicians and clinics have to demonstrate a particular set of criteria. The sets of criteria will become increasingly more complex. Stage 2 criteria should be released probably right around the first of the year for public comment. And then there may or may not be a stage 3. There's been some discussion about whether that's going to occur or not. Now, interestingly, in the Medicaid programs, for the first payment, you do not have to demonstrate meaningful use. What you have to demonstrate for the first payments under the Medicaid programs are your intent to adopt, implement, or upgrade your systems. And in our state, whose plan was just approved by CMS for this, that is, you show proof of a contract with a vendor to do that. And each state got to determine how much money of the total pot was available on that for that first payment. So it's quality reporting, it's demographic reporting, it's patient availability to electronic data, because patient empowerment is part of this. One of our biggest health challenges as a nation is obesity, and guess what? If I'm your provider, I can't fix that problem for you. It is about you fixing that problem. But if I can give you the data for you to see how you're doing, maybe you will fix that problem. And then maybe again we'll have economic and clinical health.
And are all hospitals doing this meaningful use?
All hospitals would like to do this meaningful use. There's a huge chasm between physician vendors and processes and hospital implementation. There's hardly a hospital anywhere that does not have some part of their data electronic. Usually it's the lab they start with, but meaningful use requires that all of your clinical systems be interoperable and available to each other, and that's really where the challenge comes in. So they would all like to, because it's big bucks. Now, if they don't do it by 2015, the stick kicks in, and they start getting reductions in their payments from Medicare. Oh, that's wonderful, because we're getting paid so much already.
And same for doctors?
Yes, same for doctors. Not from the Medicaid programs, only from Medicare. I'll have a copy of this available for you. It's the executive summary of the lovely document, as you know, that come out from the federal government, but it has some great visuals in it. You'll enjoy them, I think.